Hello, everyone, and welcome to the Parkinson's Foundation Expert Briefing. I'm Dr. James Beck, Chief Scientific Officer of the Parkinson's Foundation, and it's a pleasure to have you with us today. In today's briefing, we will explore the wide spectrum of motor symptoms, how they evolve, and strategies for managing them. I think it's going to be a really interesting topic today. But before we get started, we'd like to get a sense of who's joining with us today, as we always do. We're going to launch a poll, and if you're joining us on Facebook Live, just be reassured you can put a little bit about yourself in the comment section. And in this poll, we're just trying to get a sense of who our audience is today. It tends to be fairly consistent with a lot of people with Parkinson's, as we expect, but sometimes we have folks from other backgrounds who join us, and it's always nice to really understand what their connection is to Parkinson's disease as that. So we'll leave that up for just a little while longer, and hopefully we'll get that. And I hope wherever you are, the weather is at least somewhat nice. I'm on the East Coast, and we finally have a break in the weather. I understand, though, it's not going to last. So anyway, thanks to everyone for sharing your connection to Parkinson's disease. And let's see what we've got as a result of the poll. Great. A lot of people with PD are joining us today, as well as their loved ones as part of the process. And we have a good number of scientists and healthcare professionals. So that's great to see. So welcome, everyone. And we're happy to have you here. So before we begin our formal expert briefing, I always just kind of talk a little bit about the foundation and just remind everyone we're a nonprofit foundation that's really dedicated to improving the lives of those living with Parkinson's by enhancing care and advancing research. So it's important to remember, as we do always, our efforts are deeply rooted in the collaboration we have with the Parkinson's community. So that means everything we do, we ensure is aligned with the needs and priorities of you, those people living with Parkinson's and those who support them. And so, as I've said, today's program is just another example of how we're working with you to meet those goals. One of our key initiatives that we offer through the Parkinson's Foundation is PD Generation. This is our opportunity to offer free genetic testing and counseling to people living with Parkinson's. Any adult who wants to participate practically can. By participating, you can learn about your genetic connection to Parkinson's and contribute to research. And that will hopefully drive new treatments and one day a cure for those of us living and fighting Parkinson's disease. So we encourage, if you've already participated in PD Generation, share this opportunity with your community. And I believe that together we can really make a difference in tackling PD through this idea of sharing research and resources across the community. So for your convenience, we're going to be, as we always do, recording our expert briefings. They'll be archived. And if you've signed up for it, you'll get an email with a link to the recording, which you can share to other individuals who may want to participate. And if you've missed part of it, you have to walk away. Don't worry, it will be here for you to watch again and again. So now I'd like to just move on to introducing our sponsor, Light of Day, who's here to help support our PD Health at Home series. So we really am very pleased to have them on board as a sponsor for us. And now I'd like to introduce Dr. Pablo Coss. He's a movement disorder specialist and assistant professor of neurology at UT Health San Antonio. Dr. Coss completed his Doctor of Medicine degree at UT Health Sciences Center in Houston, and then went on to complete a neurology residency and movement disorder fellowship in San Antonio, where he has since stayed on as a faculty in the movement disorder division. Dr. Coss specializes in the diagnosis and treatment of a broad spectrum of movement disorders, including Parkinson's disease, and particular focus of his is deep brain stimulation for PD and other movement disorders. He's focused on botulinum toxin injections and has an interest in Huntington's disease. Dr. Coss has a strong background in education, so we're very pleased to have him here today. He enjoys teaching neurology residents, movement disorder fellows, students, and the community. He serves as the Assistant Movement Disorder Fellowship Director at UT Health San Antonio. Dr. Coss has a strong passion in serving the underserved communities in South Texas and leads a movement disorder clinic in the border town of Laredo, Texas. Dr. Coss, thank you very much for your time and joining us today.
Thank you, Dr. Beck, for the introduction. Um, I'll get started here sharing my screen. Let's see. If I could just confirm that everybody can see the presentation.
Yes, just go on presenter mode.
Should be there already.
Looks good, thank you.
Okay, great. All right, everybody. Thanks for having me. Thanks for giving me the opportunity to talk about the motor symptoms of Parkinson's disease, the tremors, and all of the other symptoms that folks with Parkinson's struggle with regards to movement of the body. Greetings from sunny San Antonio. Hopefully, everybody else is having a break from the bad weather of the winter. I have no conflicts of interest to disclose in relation to our topic today. The what I want to highlight today in terms of learning objectives is first to I list and describe and learn the vocabulary of all of the motor symptoms that are associated with Parkinson's disease. And then after we've done that, we will discuss the underlying physiologic brain disorder that gives rise to these motor symptoms. And then the second half of the talk will be focused on various treatments when it comes to medications, non-pharmacological treatments, and surgical treatments that are available to help the motor symptoms of Parkinson's disease. Just to put it in a bit of historical context, what we're talking about when we talk about motor symptoms, we want to go back to the very first description of Parkinson's disease by Dr. James Parkinson in 1817. He wrote this essay called he wrote a paper called An Essay on the Shaking Palsy, based on his observations of several cases of the condition around London. And he identified what would later be called the cardinal or motor symptoms of the disease, starting with a particular kind of tremor called a rest tremor, the flexed posture of folks with Parkinson, many folks with Parkinson's when they walk, the some of the walking changes, what they call the festinating gait, and then an insidious progressive course. That was in 1817. And then in the 1880s, Dr. Jean-Martin Charcot, working in Paris, further categorized the main motor symptoms of Parkinson's and highlighted the symptoms of bradykinesia and rigidity. And we'll talk a little bit more about what that means in a second. And he was also the first one to promote calling the condition Parkinson's disease in honor of James Parkinson for describing it 50 years earlier. So when we talk about the motor features, again, we're talking about symptoms that have to do with disorder of movement, of difficulty moving. That is both making your body move when your brain and your mind want it to move purposefully, and also making your body still when your brain and your mind don't want it to move, when they want it to be still. And folks with Parkinson's have difficulties with both of those issues. First of all, they have the tremor. Most of us, we think of somebody with Parkinson's, we think about somebody shaking, some part of the body shaking, usually the arm. And we have different kinds of tremor that can affect people with Parkinson's, so we'll get into in a little bit. Even more actually fundamental and defining of the condition of Parkinson's is this other motor symptom called bradykinesia, also known as akinesia. Some people call it hypokinesia, but all of that is various ways of describing slow and small movements. So folks with Parkinson's, when they're trying to move purposefully, they might find that their movements are smaller or slower than they used to be in the past. In addition to that, there's also rigidity, which most of the time we colloquially call stiffness. But that's really an excess activation of muscles when they should be relaxed, which leads to this resistance to passive movement of the limbs. And then there's postural instability, which refers to loss of balance, reflexes leading to stumbles and falls. We will talk about several other motor symptoms that are kind of in relation to these, but these are the four what we call cardinal features that we actually also are very important to identify at least two of them to make the diagnosis of Parkinson's disease. Throughout the course of the video of the presentation, I am going to be showing various videos of patients that have passed through our clinic at UT Health San Antonio. Very common practice in our specialty to take videos of our patients, both to track their progress over time during certain key steps, like to getting a deep brain stimulator and stuff like that, and also for educational purposes for our residents and the community as well. Um, I've blurred the faces so that to try to protect their privacy, but I'm very, very grateful that they allow us to take these pictures, these videos, and share them in these kinds of settings. So starting with rest tremor. So one of the most defining symptoms of Parkinson's is the rest tremor. Many of you who have Parkinson's probably have experienced a rest tremor. A tremor per se, the technical definition of tremor is a uh, uh, rhythmic, fairly fast and continuous movement of a body part across a joint with a kind of a sinusoidal wave pattern. Uh, and broadly that's what a tremor is, but then we can subdivide that into various kinds of tremors. And the most classic form of a tremor in Parkinson's is a rest tremor, and that's a tremor that happens when the body part affected is relaxed or at rest. Whether that's hanging at your side, your arm hanging out your side as you're walking, or resting on the lap, or on top of a table. It tends to shake when the arm is relaxed, not in use. It most often affects the arms, but it can. Plenty of people have it in the legs. Plenty of people have it in other parts of their body, like their jaw or their face. Um, in the textbook description of somebody with Parkinson's, it is an asymmetric tremor that affects one arm more than the other, or one side of the body more than the other. And often you'll hear it have described as a pill rolling tremor, which describes the way that the thumb tends to rub against the other fingers as it shakes, as if you're rolling a pill between your thumb and your other fingers. Though not everybody has that quality to the tremor. So here we're going to see a good example of a rest tremor affecting a patient's uh, right arm, and also you can see the right leg shaking there as well. And you can see also that the tremor goes away. The arm stops shaking when he picks it up and starts to do these movements with it. And then it starts shaking again after a few seconds of him putting it back down. That's the typical rest tremor of Parkinson's disease. That's not the only kind of tremor that folks with Parkinson's can have. Many folks with Parkinson's, oh, and I will say also, as many of you probably know, the rest tremor itself, it can be variably uncomfortable, distracting, can make one self-conscious in public. It can get in the way of sleep if you're trying to go to bed and some part of your body is shaking against the pillow or against the sheets. So it can be, of course, a source of discomfort and disability, even if it's not affecting, intruding in the use of the hand per se. But many folks with Parkinson's also have what we call an action tremor. An action tremor is a tremor that comes out when the hand is in use or when the body part is in use, whether that's when it's in actual motion, whether it's holding a certain posture or position, or during a specific task like writing or holding a cup or using utensils. And so here we'll see, and many folks with Parkinson's have a combination of a rest tremor and an action tremor. And so we'll see both here in this video. Uh, there he is. He has his hands up, and his hands are shaking even when they're up, and so we call that a postural tremor. As he tries to make purposeful movements with his hand, the finger tapping and all that you're going to get used to seeing. Uh, the blurring there might get in the way, but I think you can still see the hand is still shaking even as he's trying to move it. So that's a kinetic tremor. And then even when the hands are relaxed in his lap, he's still shaking. So that's the rest tremor. So he has uh, uh, multiple categories of tremor affecting him. And you can imagine how that would get in the way of many activities of daily living and be very disabling. Uh, Again, moving past the tremor and really getting to the heart of Parkinson's disease is this symptom called bradykinesia, or a slowing or shortening of voluntary movements, and this can affect the whole body or various limbs and other body parts. When the facial expressions become slow and small, people develop this kind of what we classically call a masked face, as if a person's wearing a mask that doesn't make expressions. It can affect the movements of the hands, which can make it hard to accomplish fine motor tasks like ripping a bag open or unscrewing a cap or using tools, etc. It can affect a person's ability to stand easily from a chair. It can affect a person's ability to walk, and we'll talk more about the specific walking changes in a second. And this, for most people, translates into some amount of disability because it becomes very effortful. It leads to a lot of fatigue to do your daily tasks because your body is slow to move when you want it to move, and it takes longer to accomplish tasks that you used to be able to do quickly. So here we have an example of bradykinesia. You can see how when I ask him to tap his fingers and I'm asking him to tap them as big and as fast as he can, he makes these very, very small and very slow taps. So it's a combination of the slowness and also the smallness of the movements. Here I'm asking him to open his hand as wide as he can, and he can't really stretch the fingers very much, and they're very slow movements as well. And here he is trying to stand, and he's he's really not able to. This is quite severe, a severe form of bradykinesia. Um, I'm asking him to stand, and he's actually putting in some effort into standing, and he's not able to. So his spouse is going to come and help him stand up, and he stands very slowly. And he even has a bit of trouble standing, and he kind of almost wants to fall back down or sit back down quickly. Okay, so that's bradykinesia. This is a similar example, but it shows about the same thing as we just saw. So for the sake of time, I'm gonna skip this one. Um, the next cardinal motor symptom that we're going to talk about is rigidity. I don't have a video to show you for this because this is not something that can be seen easily on video. It's something that has to be felt. Patients feel it as a tightening of the muscle, as an uncomfortable soreness or stiffness of the muscles. But we feel it on exam by moving the arms and legs at the different joints, at the elbows, at the wrists, at the knees, at the ankles, and seeing how much resistance there is when a person is trying to relax as much as they can to our passive movement. Often you'll hear us to hear this kind of rigidity as the limb feels like a lead pipe, like you're trying to bend a lead pipe because it's so stiff, or cogwheeling in the sense that the limb kind of ratchets as we're trying to move it, which is probably the rest tremor coming out as we're trying to move the limb. Um, Another aspect of Parkinson's, which very commonly affects people, but is not considered a cardinal motor symptom, is something called a dystonia. This is different from the rigidity we just described because when a person is rigid, their limb is relaxed and at rest. It's just when you try to move it that you feel the stiffness. In dystonia, the limb wants to assume, or the body part wants to assume a certain abnormal position. It very commonly affects the hand. It might make the fingers want to clench up or uh, uh, put themselves in a different position. It very commonly affects the leg, and the most classic form of that is a turning in of the ankle and a curling of the toes, which can be very painful. And it often affects the face or in particular the eyes. So some people with Parkinson's, they might have trouble opening their eyes voluntarily because the muscles of the eyes want to close them tightly. Um, and oftentimes it comes along with a jerky tremor, a dystonic tremor that can kind of overlap on the other forms of tremor of Parkinson's. Here we're going to see the typical ankle inversion or foot inversion dystonia in a patient with Parkinson's disease. You can see there as her feet are dangling and should be relaxed and just lying gently on the ground. That left foot wants to turn in and is shaking. And the more she's describing there to me how she likes to try to make it stop with her other foot. So she tries to rub it or put it down. But you can see how the foot turns in more and more and more as she talks. And so that is a dystonia of Parkinson's disease. Many other causes of dystonia as well, not just Parkinson's, but it's often a motor symptom of Parkinson's. Okay. Another bothersome motor feature is the vocal problems, which can come in a lot of in a variety of different forms. Oftentimes, it's reduced volume. The speech becomes kind of monotone, which makes it hard to kind of put emotional expression in your speech. Articulation of specific consonants and vowels can get kind of poor, so it becomes slurred, hard to less intelligible. Stuttering, the speech can become rushed so that the syllables are kind of running together, makes it harder to understand. And breaths can become shallow, so you can only speak short sentences before you have to kind of take a breath and then continue speaking. Here's a sound bite of a patient of mine who has particular problem speaking because of their Parkinson's. There's going to be a lot of background noise in this video sound clip. But take my word that even without the background noise, it's kind of hard to understand what he's saying. Let me put the volume up for this one. Tell me the months of the year.
Months of the year.
Uh-huh.
January, February, March, April, May, July.
Okay. Tell me a little bit about what it feels like when you're off in terms of your speech. How does it affect you?
Feels like speed. Here. Also, like,
So if you're feeling the need to lean in closer so that you can understand what he's saying, that's what it feels like in the room as well. And that is a combination of these of the reduced volume, the poor articulation, and then the rushed or festinating speech pattern. Um, and I shall say, and many of you living with Parkinson's know, all of these motor symptoms affect people to different degrees. So some people have everybody has some combination of these symptoms to different degrees. So just because I'm describing them here doesn't necessarily mean that they're going to be a part of a given person's Parkinson's disease. Something to keep in mind. Um, Going to the walking, of course, we usually think of somebody with Parkinson's as having their shoulders stooped forward, not swinging their arms very much, taking small shuffling steps where they don't pick up the toes and the foot kind of slides along the ground. And then we'll talk more about it later in the talk, but progressive problems with balance. Festination. I don't have a video of the festination, but that's a sense that many of my patients describe of feeling like they're speeding up or the top of half of their body is getting too far out in front of them, and they're taking these little steps to try to keep up, and that might eventually lead them for them to fall. And then retropulsion, which is if you get knocked backwards, you take a bunch of little steps to try to catch yourself instead of just hopping back. This is an example of a typical Parkinsonian gait. You can see, of course, she has a rest tremor, but on top of that, she takes these short strides. One foot is barely clearing the other as she walks. She's not picking them up very much, and she's not swinging her arms very much. One particular problem that some people with Parkinson's run into usually after years of having the condition is, in addition to the walking issues we just described, is this other issue called freezing of gait or freezing, where the feet feel like they get stuck, frozen, or magnetized to the ground, and you have to try multiple times to try to take that next step, to pick the foot up to take the next step. Tends to happen often around thresholds, like narrow places like doorways or crowded areas. When a person is turning, they tend to freeze, and when they first start to walk after they get up, they tend to freeze a few times. And that is it's very, I understand it's very fatiguing to try to walk with the freezing, and of course it can affect a person's center of gravity and lead to falls. Okay. Here's a man trying to walk down the hallway, and you can see how he's not really taking steps. He's just kind of picking up the feet, trying to get them to take the next step. Uh, all right. So we've gone over there the major motor symptoms of Parkinson's disease. Uh, there's a question of what underlies those symptoms. What is the brain dysfunction that causes the symptoms? And it's good to go over that in a kind of a high level overview, but so that we can understand the way we treat Parkinson's, the symptoms themselves. And so I won't belabor this too much. Let me see if I can pull up the laser pointer. Yeah. Um, but the big picture is that whenever you want to produce a voluntary movement, say extend your arm to reach for a cup or write or anything else that you want to do with your arms, a signal from the surface of your brain called the cortex is sent down deep into the brain to a circuit of brain cells that process movement commands and allow your brain to regulate all of the voluntary movements that it makes. So that signal needs to get processed between several clusters of brain cells connected to each other deep inside the brain. And if they agree with the brain signal promoting a movement, they will send an excitatory signal back through a part of the brain called the thalamus, back to the cortex, and that will excite the brain in general and produce the movement of the body that wants to be produced. And that cluster of nerve cells that does that processing deep in the brain are called the basal ganglia. This is a diagram of how the basal ganglia are connected to each other. This is what medical students learn about the connectivity and the physiology of this part of the brain. I'm not going to go into much detail about it here, but suffice it to say that the signal comes from the cortex into the basal ganglia, which is this network here, this square here, into a part of the brain called the striatum, which is kind of the input nucleus for the basal ganglia that takes all of the signals from other parts of the brain for processing. And that it goes through one of two pathways. It goes through a pathway that directly connects it to the GPI, or it goes through a pathway that takes a bit of a detour. If the signal goes through the direct pathway, that excites the brain and produces the movement. If it goes through the indirect pathway, that suppresses the signal and inhibits the movement. And both pathways are necessary in order for your brain to uh, make you move when you want, make your body move when you want it to move, and stop it from moving when you don't want it to move. And those are regulated by dopamine cells within the striatum. Both pathways are regulated by dopamine signaling, which comes from a different part of the brain called the substantia nigra. And as many of you know, the problem with Parkinson's is the lack of dopamine coming out of the substantia nigra. Let's look at that a little bit in more detail. Here's another way of looking at that part of the brain. I know it's pretty complicated here. I'm going to zoom into the basal ganglia. Here's a substantia nigra. It's this pink nucleus here. It's a cluster of brain cells. Here's in blue, here's one brain cell sending its connection, its axon, its wire to the striatum, which is this part here. And so all of these brain cells that are sending out their little connections, they're producing dopamine and kind of squirting it into the striatum, and that's regulating the movement signal processing within that part of the brain. Here is a picture of the substantia nigra, what it looks like actually in the brain through a brain slice of a post-mortem brain. This is the midbrain. It's in the brainstem. It's a very small part of the brain. And here, this blue, purplish streak is the substantia nigra on one side of the brain, and then the other on the other side of the brain. They're pigmented brain cells, so that's why they have that blue color. And you can see as a person with Parkinson's loses those brain cells, it also loses the pigmentation, and you get this kind of uh, uh, pale color. So this top brain is somebody with Parkinson's, and this bottom brain is somebody who didn't have Parkinson's, whose substantia nigra was healthy when they passed away. Without those cells, there is not that you lose that chemical signal, that dopamine, and it makes it so that there is less traffic through the direct pathway, so less voluntary movement. And then there's also simultaneously more traffic through the indirect pathway. And the combination of those two things makes it so the body just doesn't move as quickly and as readily as it's supposed to. And it's more tense when it's not supposed to be. So that's really what underlies the rigidity and the bradykinesia, the difficulty walking of Parkinson's disease. And so our answer to it is to replace the dopamine. That is the main way that we know how to help folks with Parkinson's disease. So we're going to get into treatment here. And before I get into medicines, one of the I do want to emphasize one of the most important ways of replacing dopamine, and really the most important thing that you can do for yourself as somebody living with Parkinson's, is to exercise. There is a large body of evidence that has been building up over decades of how important and how effective regular, moderate to high intensity aerobic exercise, really high intensity aerobic exercise, how much of a difference that makes to folks living with Parkinson's. And it's not just, when I first started treating people with Parkinson's during my fellowship and residency, I would recommend exercise as a long-term thing because the studies show that over years, folks who exercise regularly, their motor symptoms are more stable for a longer period of time than folks that don't exercise regularly. And so I was recommending it as a long-term treatment. But hardly a week goes by where my patients don't tell me that they started exercising and it makes a difference on the day that they exercise. When they exercise in the morning, They feel faster, they have more energy, less fatigue, their tremor's not as bad, they sleep better. All of the various benefits of exercises are an immediate effect on top of the long-term benefit to the course of the disease. And so I'm talking about, usually we're talking about aerobic exercise, like a treadmill, an elliptical, a stationary bike, a bicycle itself, if it's safe and you're not going to be at risk of falling on the bike, swimming, really anything that you like to do that has an aerobic component to it, that's going to get you sweating, that's going to get you out of breath, winded a bit, and it's going to get your heart rate up. Is really the best thing that you can do, and you should be doing it about at least 3 times a week, if not more, if not every day, ideally. But there's various kinds of exercises that have been studied. Aerobic, we talked about. Strength exercises are also helpful. Balance exercises are very good for to avoid falls and strengthen your leg and your core. Stretching exercises are good to help with that uncomfortable tightness, the rigidity. And then functional exercises, things like dancing, boxing, martial arts, are really good for you as well. Um, Moving on from exercise, though, and you definitely need to exercise. That's the most important thing. But we do have these medications that are symptomatic treatments that are very helpful for folks with Parkinson's disease. And chief among them, central to our regimen for anybody living with Parkinson's, is this medication called carbidopa levodopa, which I'm sure most of you are familiar with. It was developed in the 1960s, and yet to this day, it still remains the most effective treatment that will help folks with Parkinson's. The lead, just to For you to understand why it has this complicated name, it is two different medicines. There's the levodopa and then there's the carbidopa. The levodopa is the active medicine that it produces the clinical effect of helping Parkinson's symptoms. It crosses the blood-brain barrier, which is this kind of specialized wall in the lining of the blood vessels within the brain that keeps a lot of stuff from coming into the brain from the blood. But it is able to cross the blood-brain barrier, and once it gets into the brain cells in the substantia nigra that make dopamine, um, it is metabolized into dopamine to help bolster the dopamine signaling that is going to have the good effect on that basal ganglia circuitry that we talked about. The carbidopa, by contrast, it is not active. It does not cross the blood-brain barrier. It does not get turned into dopamine. It blocks the rest of the body's metabolism of levodopa, which means that more levodopa is able to get into the brain to have its good effect. And also, it is not turned into dopamine by other parts of the body, like the GI tract, which is what causes one of the most common symptoms of side effects of levodopa, which is nausea. And so almost all forms of levodopa come with carbidopa because it is having these beneficial this benefit to the way that the levodopa affects your body. There's various forms of carbidopa levodopa. Um, there's an immediate release. So the old name for that is Cinemet. That's the one that most people are on when they first start to take the medicine. There's an old form called controlled release with an enteric capsule, which is used sometimes as well. And then there's the newer versions of extended release carbidopa levodopa. One of them's called Rytary, and the newest one's called Crexont, which have some innovations in the capsule and have some in the little micro beads inside the capsule that carry the medicine, which makes it so that it kicks in strong, but it also lasts longer than the standard immediate release medicine. Uh, all of these are taking multiple times a day, unfortunately. The half-life of levodopa is such that you really have to be taking it at least two times a day, but more often three or more times a day for it to have a continuous effect that doesn't wear off in between doses. We'll look at exactly what effect we expect from levodopa in the next slide. But there's also these continuous infusions. The most recent one that we're using a lot of nowadays is called Vyalev, which is a subcutaneous infusion. This pump that is connected by a thin cannula to a port that puts the medicine just right underneath the skin, so it's not very invasive. and it gives a continuous infusion of the medicine 24 hours a day. There's also an inhaled version of levodopa, like an inhaler like you would use for asthma, that is used kind of as needed because it kicks in very quickly. When people are feeling like the effect of the medicine is wearing off and they're not feeling good anymore, they can use the inhaler to kind of get a quick kick back in. The possible side effects of this medicine, uh, nausea is very common, unfortunately, but other side effects are it can make the constipation of Parkinson's worse than it already is, can make people dizzy, can contribute to low blood pressure for some people, drowsy sometimes, and then not usually something that people experience early on, but as the years go on living with Parkinson's, the medicine can contribute to the development of hallucinations, unfortunately, and these other abnormal movements called dyskinesias. We'll talk about that in a minute. It can also make some people a bit impulsive and have difficulty controlling their impulses, which is something that you should be in conversation with your doctor about. But here is the what we expect the levodopa to do. The good effect of the levodopa. You'll remember that first patient that we saw um, with the rest tremor on the right arm and the right leg. That was him coming off of his medicine without taking the levodopa for 12 hours. And then we gave him the medicine and he took it, and we waited about an hour in clinic. And then we took this next video. For me. And you can see that his tremor has gone away, both of the arm and the leg. Um, we'll wait for him to do something with the other arm to just make sure that it's actually gone. And yeah, so that tremor has gotten a lot better. And now uh, we'll move on to this patient. Similarly, this other patient here um, came to the clinic in the morning without taking his first dose of the medicine, and we took this video of him with the medicine worn off. And here he never has much of a tremor even without the medicine. But what you can see is again the smallness of his movements and the slowness of his movements there in the finger taps, here in the hand opening. The hand really doesn't open very much, and especially on that left side. If we could feel the tone of his arms and legs, we could probably feel that he's fairly rigid. Now we're having him flip his hand up and down, and you can see there again, the hand doesn't really go all the way up or all the way down. It kind of, there's a reduced amplitude of that movement. Here we're having him tap his toes, or he will in a second. That right foot taps pretty good, but the left foot, you'll see, doesn't really lift very much off the ground. Now he's going to try with the left. And yeah, it gets kind of stuck, doesn't want to come up very much. So now we see him 1 hour after he took his medicine on the same day, just about an hour after that first video was taken. And this is with him with the levodopa now kicked in. The blurring, I'm sorry, gets in the way a little bit of the video there, but the finger movements are faster than they were before. They're still kind of small, but now let's look at the hand movements are much bigger. It's not getting small as quickly as it was before. It's staying big, big stretching of the fingers. Similarly here, he's able to stretch them wide, whereas he wasn't able to before. That left hand now is going to come up a lot more than it was before. Has a bigger amplitude there of the rotation. Let's look at him tap his feet. He's more active in the chair. He's spontaneously moving more. And the left foot also taps bigger. Doesn't get stuck as much. I almost forgot to show on the off video. Let's watch him try to stand up. So we've asked him to stand up. He's trying. He's giving it a good try there. He's going to tell us that he's not really able to on his own. And so one of our nurses is gonna come and help him. Okay. Now let's watch him stand after he's taken his medicine. We've asked him to stand up, and he stands up easily. So that's what we want to see. That's why levodopa is so helpful in the in treating the motor symptoms of Parkinson's disease, because it really makes a big difference to the tremor, to the stiffness, to the bradykinesia, so that people can move easier and feel like they have more energy and can get things done faster and walk better and all that. Um, if that was all there was to treating Parkinson's and everybody, enjoyed the benefits of the levodopa forever, then it would be a lot more manageable of a condition. But the problem is that as the years go on, we tend to come into a period of complications of the medicine, what we call motor fluctuations. And here we have the 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 textbook kind of progression of Parkinson's disease over years. And again, I want to caution people looking at this. This is not the way that it is for everybody with Parkinson's disease. Many people have a very different course through the years of the condition than what this shows. So don't look at this and think, oh, and start the clock on these numbers, because you got to you got to take the condition day by day. There's a lot of variability. But usually most people may start to have these motor fluctuations in years three to five, in which the effect of the levodopa, the good effect that we just saw in that video, starts to wear off sooner than it used to after each dose. So if the effect of the levodopa used to last 6 hours, after a few years it may only last 5 hours or 4 hours. And so if you were only taking it 2 or 3 times a day at first, you may have to start taking it more frequently to try to pave over those periods of wearing off. Um, so some folks might fluctuate between feeling on and feeling off throughout the day, depending on their dosing schedule. And then on top of that, uh, uh, another side effect of the medicine that starts to creep in during that period are what we call dyskinesias, which are these other involuntary movements that are entirely a side effect of the medication. And then, setting that aside, and we'll talk about this a little more at the end. There, many folks start to struggle more and more with walking and balance and the freezing that we talked about. So we're going to talk a little bit about what we do about those things. Um, First, to say, this is an example of what dyskinesias look like in folks with Parkinson's disease. They can be many things for many people. So some people develop the kind of a writhing movement or a wiggling movement or kind of a fidgeting of their arms and legs or their head. Some people rock side to side or back and forth when they're standing. Some people, it looks more of like a dancing movement, or a posturing movement, almost like a dystonia. It can affect any body part or the trunk or various body parts together. It's usually what we call a peak dose side effect of the levodopa. So when the levodopa is at its strongest concentration within your system, about an hour after you take the medicine, an hour to 2 or 3 hours, that's when the dyskinesias rear their heads, and then they kind of go away as the effect of the medicine is subsiding. Um, so here's what that looks like. Uh, I won't show you the video where um, we see how much of a difference the levodopa makes to this gentleman's walking. It makes a huge difference. Takes away the freezing and the stutter stepping and all that. But suffice it to say that these wiggling movements of his head that you can see through the blur effect there, and of his legs and of his trunk, kind of a side to side rocking. These are dyskinesias, levodopa induced dyskinesias. It depends on the severity of them and what body parts they affect and a person's lifestyle, exactly how disabling or uncomfortable these dyskinesias are. I certainly have a lot of patients who have mild dyskinesias where they don't even notice it themselves, and it's just me or their family who picks them up when we're watching them do things. But then again, if it gets severe enough, and if a person is uh, uh, if it's getting in the way of a particular hobby or work, um, they can themselves be a very disabling part of the condition. And if they stop taking their levodopa, the dyskinesias will go away, but then they'll be off. And so it becomes a kind of a balance of enough dose to help their symptoms, but not so much to cause the dyskinesias. And that's where our advanced treatments come in. I'm not going to spend very much time on this, but there just suffice it to say that there are various medications that are considered adjunctive treatments. I have a list here of all of them, the most commonly used ones. Um, Suffice it to say that that in general they are used in addition to levodopa to improve the duration and the effect of the levodopa, kind of as an additive to reduce the amount of off periods when a person starts to wear off with the levodopa. Some of these are used on their own. I won't get into that very much. When the symptoms of Parkinson's are mild at the beginning of the condition, in the first few years of the condition. Uh, None of these on their own are as effective as levodopa. They don't help as much as levodopa, but when a person's symptoms are mild, they may help enough that they can get by. But eventually, everybody with Parkinson's really should be on carbidopa levodopa, despite the complications that we've talked about so far. The problem with adding more of these medicines to somebody who is already taking levodopa is that they are going to contribute to the side effects of levodopa. So they will also contribute to dyskinesias. They may contribute to low blood pressure, to hallucinations, on top of the levodopa. The only one, just to point one out here, that shouldn't contribute to dyskinesias is amantadine. Amantadine is often used actually to suppress dyskinesias. It's the unique amongst our Parkinson's medications is that in that it reduces the severity of dyskinesias caused by the levodopa. So oftentimes many people will be on carbidopa, levodopa, and amantadine, and oftentimes the amantadine is used to suppress the dyskinesias of the levodopa. Okay. So what to do at the point where the motor fluctuations, the wearing off, and the dyskinesias are becoming a major problem? Um, we can't really add more medicines because that'll make the dyskinesias worse. We can't really lower the dose of the levodopa any further because then you'll feel more and more off throughout the day. So we're kind of stuck between this rock and a hard place when it comes to medications. And that's where these surgical and more advanced treatments for Parkinson's come in, like deep brain stimulation. Deep brain stimulation is a procedure that is done very, very, very commonly nowadays. It's part of the standard of care for folks with Parkinson's disease in the U.S. and across the world. And any movement disorder center uses deep brain stimulation a lot to help with folks with Parkinson's disease. It's FDA approved for the treatment of Parkinson's disease, tremor, and motor fluctuations. It's also used for other movement disorders, essential tremor and generalized dystonias. But specifically, when we offer it to folks with Parkinson's, we have three main goals, three things that it's going to accomplish. We expect it to improve the motor symptoms of Parkinson's, much the same way that levodopa does, with some caveats to that. Um, we expect it to reduce the motor fluctuations, so to reduce the off periods, because it's a technology, a treatment that is going to be working consistently 24 hours a day without kicking in or wearing off the way that levodopa does. And it's going to reduce the medication burden. So most people can reduce the levels of the doses of their medicines and come off of some of the extra medicines once they have a deep brain stimulator. What a deep brain stimulator specifically is a set of thin wires that are implanted surgically into the brain, deep into the brain, into that same part of the brain that we called the basal ganglia that I showed you earlier, through small holes in the skull that are made by a neurosurgeon. It's usually, most people with Parkinson's will have a wire in each hemisphere, on each side of the brain, left and right, um, to help the symptoms on both sides of the body. The wires come out through these caps in the skull, and then they go the on the outside they are tunneled underneath the skin, so there's no wires poking out of your head. People can't usually tell that you have one of these. Um, and they go behind the ear, down the neck, and then they connect to a pulse generator, a battery that is implanted in the chest underneath the skin, much like somebody with a cardiac pacemaker would have their pacemaker on their chest. Very similarly, except for the wires go up the head and into the brain. Here you see in cross section of the brain the wire going through the white matter, the brain tissue here, and then the tip of the wire ending at the globus pallidus, which is one of the clusters of brain cells in the basal ganglia. We also sometimes put it into a different part of the brain called the subthalamic nucleus, which is also part of that same circuit. So there's some nuance about why we might do the globus pallidus for one person and the subthalamic nucleus for another person. but suffice it to say that they're both stimulating both clusters of brain cells produces a very good effect on the motor symptoms of Parkinson's. This is a neurosurgical procedure, so while it is very helpful and it makes a big positive difference to folks with Parkinson's, there are possible side effects, risks to the procedure. Like any kind of invasive procedure, there is a risk of hemorrhage. In this case, it would be within the brain, and that can be dangerous, but it's fairly rare. It's 0.5 to 2% of people have a hemorrhage from the procedure. And then there's similarly a small risk of infection, which might mean that we need to take the device out. Um, there are possible side effects that are due to the stimulation itself. For some people, it may make their arm tingle, or it might cause a contraction, an involuntary contraction of a muscle, or affect a person's cognitive or mood symptoms. Those that kind of side effect is stimulation dependent. There's a lot of programming that goes into making a deep brain stimulator work well. And so by programming it in a different, changing the settings of the stimulation, we can often make these side effects go away, and tinker with the settings until we get it working well without any of these kinds of side effects. The way that DBS works, again, here we have the cap in the skull and the wire going into the brain and ending, in this case, in the subthalamic nucleus. Here we have a blown up diagram of the tip of the wire. It has these electrodes on it, and we activate individual electrodes. In this case, we're activating electrode 1 and electrode 2. You can imagine that these are the all of the brain cells connected in the tissue around the wire, even though it's not shown in this picture. Um, it's shown over here actually. Here's one side of the wire, really zoomed up, and here are all different kinds of brain cells in the wire's vicinity. The active electrodes create an electric field, which is depicted in this translucent blue sphere. That's the amount of tissue that is being subjected to that electric field, and it changes the electric firing properties, the electric signaling properties of the brain cells in that vicinity. It snaps them out of these abnormal brain cell rhythms, these signaling rhythms that are because of the dysregulation of the lack of dopamine. It snaps them out of those rhythms and puts them more into a normal, healthy firing rhythm. And that produces this effect on the larger movement networks of the brain that produces the symptomatic benefit of the stimulator, much like the symptomatic benefit of carbidopa, levodopa, of replacing dopamine. So this is not to be clear, to clarify a common misconception. This is not doing anything to your brain's levels of dopamine. This is simulating the effect of the dopamine on the downstream networks with an electric signal instead of a chemical signal. Here is a patient with Parkinson's disease before and after DBS. Actually, in both videos, it's on the same day, but this is with the settings on the DBS turned off. So this is his symptoms without the effect of the DBS. You can see how tremulous he is, how much of a rest tremor he has there. And then not just the rest tremor, but you can see even when he picks his arms up, how much of a postural tremor he has in both his arms and the rest tremor in the legs. And here he is with the DBS on. And this effect happens within seconds to minutes of turning the DBS on and to the right setting, to the optimum setting. And you can see now he's really not tremoring at all, or only very mildly in one of his hands. So that's the effect of DBS, much like what we see with the levodopa on and off videos. Here's another quick one showing how the DBS can help the walking. Here's a patient struggling, with short steps, not swinging his arms very much, getting a little frozen here as he tries to turn around. His feet get kind of stuck on the turn, and he's moving very slowly. And now here he is with the DBS effect after turning on the DBS. And you can see how much wider his steps are, how much faster, how much he's swinging his arms more, and how he doesn't freeze anymore when he turns. So a big success there for DBS. It's going to make a big difference to his day-to-day activities. One other advanced treatment that I want to talk to you guys about, I know I'm getting short on time here, but is the focused ultrasound technique. This is newer than deep brain stimulator. Deep brain stimulator has been around for about 30 years. This has only been around for about 10 to 15 years. Um, this is very exciting because it is in a way a non-invasive procedure. It's at least an incisionless procedure uh, in which a beam of ultrasound waves is emitted into the brain. It penetrates through the skin, through the skull, through the outer layers of the brain without any kind of hole in the skull or incision in the skin. It just penetrates through the tissues harmlessly. And the ultrasound waves focus on a small part of the brain in the similar network of brain cells that we've been talking about. And in that part of in that little cluster of brain cells where the ultrasound beams focus, it causes heat in the tissue and it burns it. It cauterizes that tissue. It essentially ablates that cluster of brain cells to shut down their abnormal signaling. This has been around for about 10 years, specifically to help the tremor of Parkinson's and also essential tremor. It is just in the last year or so, approved and being used more in a slightly different part of the brain to help the other symptoms of Parkinson's in addition to the tremor, like the bradykinesia and the rigidity. It's a one-time procedure. You go in, you get the procedure done on one day, and then you go home, and then the effects should be long-lasting. Theoretically, should last years to help the symptoms of Parkinson's. So, this is definitely an alternative for a lot of people to the deep brain stimulator. But there is a complexity and a nuance for any given person, depending on the risk profile for complications of either procedure and what we want to get out of the procedure, what the main symptoms that we want to tackle, whether or not they're more benefited by a focused ultrasound treatment or by the deep brain stimulator. Um, should I keep going a little bit, or should I stop here?
I think now might be a good time to stop just to give us some time for some questions,
Sure,
Dr. Koss, if
sure,
you do
yeah.
not mind. I think that's really fantastic. It's really great to see some of these videos that you presented because it really hard to describe. You know, as they say, a picture's worth 1,000 words, and I guess a movie's maybe worth a million. So just really being able to see that, I think, is really helpful for our audience to get a basis for that is coming in. So thank you very much for the presentation so far. And I just want to remind our audience before we jump into questions, just know that our team is working to organize the questions in the back end and feed them to me so I can talk to Dr. Koss about them. And just also get a variety of questions that come in. We're really going to focus on those that are going to be very uh, directed towards our conversation today. So thank you for those. And we have a helpline who can help more broadly as part of the process. So um, I think when I think about this, Dr. Costas, you showed some symptoms from various people and individuals as part of this process. You know, tremor is often viewed as one of the key symptoms in Parkinson's disease. But is it the case that everyone develops tremors with Parkinson's disease?
No, only even though it's kind of what we all think of when we think of somebody with Parkinson's, somebody shaking. It's only about 70% of people with Parkinson's who have a tremor associated with their Parkinson's, and for some of them, it may they may have the tremor, but it's kind of a relatively minor symptom of their condition, and they may struggle more with the slowness and the stiffness and the walking difficulties. Um, and so no, it is not a necessary part of Parkinson's disease for a lot of people. And it's also not strictly speaking necessary for the diagnosis to have a tremor. The most fundamental part of that is required for the diagnosis is that slowing down, that bradykinesia of the movements. And you saw there in various videos how we're always asking people to tap their fingers and open and close their hands. And so we're all of those we're always looking for that slowing and that decrement in the how wide the movements are.
And is that, I mean, so I think that's really a good thing to bring up here because, as you can appreciate, you probably know very well professionally, a lot of people sometimes struggle getting that diagnosis of Parkinson's disease, or they get diagnosed with PD when they don't. So, when is a tremor not a Parkinson tremor? Is that something that you can briefly touch on, just so that
Yeah,
people can be
sure,
aware and
sure.
like maybe query their physicians a bit more if there's some doubt?
Absolutely, absolutely, and you're absolutely right. I mean, there's a lot to be said about the accuracy of diagnosing Parkinson's disease and other tests that can be done to try to help with the diagnosis and all that. But we who Parkinson's specialists we try to pride ourselves in our ability to diagnose it clinically based on what the tremor looks like and the other symptoms and what the symptoms patients describe to us are, and we try to tell apart tremors based on the way they behave. Um, so and usually the to kind of give an example, the distinction that we're almost always trying to make is between somebody with a Parkinson's tremor and somebody with an essential tremor. So a Parkinson's tremor is most often it has a rest tremor component. So the tremor comes out when the hand is or the body part is relaxed. And it's usually to some extent asymmetric. So it'll be affect one arm more than the other, or one leg more than the other, or just one side by itself, as we saw when one in the first video. Um, uh, and most of the time, it actually goes away when a person starts to use their hand. So if they have that very classic rest tremor, then we're probably dealing with a Parkinson's tremor. On the flip side, if somebody has a purely action tremor, which is a tremor that only comes out when the hands are in use, and goes away when the hands are relaxed. And if it's very symmetric, if it affects both hands or both sides of the body in a almost to the same degree or exactly to the same degree, and if it affects the head too, most Parkinson's tremors don't affect the head. Most essential or a lot of essential tremors do affect the head. Uh, then we are more likely to call it an essential tremor or one of various other kinds of tremors. Um, so we do have that ability to discriminate, and for the most of the time when we use these kinds of criteria, we're correct and accurate in our diagnosis. Although, there are many people who fall into a gray area where they have some component of rest tremor, some component of action tremor. And in those cases, it may be kind of hard to tell just by looking at the tremor what kind of tremor it is. Then we're also looking at, do they have bradykinesia? Do they have a rigidity? And that will also kind of sway us one way or the other. We look at them walk to see if there's walking changes that look like a Parkinsonian change. And then we ask them all these other questions that we haven't really talked about today about the non-motor symptoms of
Yeah.
Parkinson's. And we use that also to support a diagnosis or refute it. And then when we're really, really not sure for whatever reason, then we rely on these other biomarkers that we can, many people are asked to do, like the DAT scan, that specialized SPECT scan, or nowadays these other tissue-based biomarkers, like we here in our clinic do the SIN1 skin biopsy quite a bit to try to confirm the diagnosis when clinically it's still in question.
Yeah, those are some really good things to consider. I appreciate that. It's, I think that's a burden all people with Parkinson's disease faces. Just generally not a straight line from A to B on getting that diagnosis. But thank you
Right.
for laying out some of those options as part of it. Tremors are this visible component of the disease. We have some people who are still working, have written in and have asked about how to manage tremors like in a speaking situation. How do you advise on that? I mean, is this something that uh, where there's a discussion about offering some medications for people who typically get other types of anxiety for speaking? Does that type of work
Yeah,
for
I think
tremor? What
so.
do you advise your patients?
Sometimes when they're very like situational tremors, like I know it's gonna come out when I'm stressed out and like speaking publicly or at dinner eating using my utensils or et cetera. There's some other aspect of a hobby or a job performance. Certainly, if we can identify that it's like an anxiety-driven tremor in that specific situation, then we do use medicines that can kind of as needed medicines. They can kind of control that anxiety, and will also control the tremor. We don't like to, depending on that medicine, those kinds of medicines, we don't like to rely on those too much.
Yeah.
Um, we'll also use some of the medicines that we borrow from essential tremor. Like a person may have Parkinson's, but they may have an action tremor that interferes with them holding a microphone or them writing in a high stress situation. And so we might give them some propranolol to help kind of relax. Like it kind of has an anti-anxiety effect and also an anti-tremor effect. And they can potentially even take that as needed. But hopefully we do a good enough job with the mainstay of the treatments like the levodopa and all that to help so that it's really quieted down even in those situations. I feel like if we're having to use kind of as needed treatments, then we still haven't controlled it well enough with all of these other treatments that we've talked about. Um, but then there's the non-pharmacologic ways. You know, unfortunately, I wasn't able to get to these because of time. Too many videos. Um, but you know there's various devices that can help Parkinson's tremor that aren't medicines like or an action tremor I should say whether it's Parkinson's or not, like a glove, the Ready Steady glove that we recommend for our patients, certain kinds of electronic devices that stimulate the wrist like the wristband that's been around now for a little while, the Cala, and various kinds of like you know like weighted utensils and stuff like that that can help with specific tremors in specific situations so that you can get things done easier without so much shaking. It's probably best to work with an occupational therapist and they can sort of go through those kind of nitty-gritty details of the functional use of your hands and where the tremor's getting in the way and what you can do about it. There's neuro occupational therapists that are experienced with helping people with tremor on top of in addition to the medicines that we prescribe in clinic.
And that's great to know. And I think just even knowing that there are options, it allows people to bring this up with their clinicians to
Right.
talk about as a way with which to move forward on it. And last question about tremors before we've got a bunch of others. As tremors get worse, does it mean that the disease is progressing necessarily, or is it is it? I mean, clearly some tremors may, as the disease goes from one side to the other side, but is there a as a tremor just becomes more prominent with time, is that something that's disease progression, or is it could just be these stress situations where we're seeing where that can
It
really
could
make
certainly
it more
be
pronounced?
it's certainly both in different situations. You know, what we usually will say is if your Parkinson's symptoms, being tremor or otherwise, suddenly get worse, like from one day to the next or one week to the next, suddenly you're very, very shaky, more so than you have been in a long time, then there's probably something underlying that worsening. There, you know, whether, you know, often the usual suspects are like an infection, like a UTI, like a urinary tract infection, or maybe some change in the medicines, or maybe you forgot to take your medicines or something like that, or you've otherwise been sick, dehydrated, etc. And so, so we're always, when it's a sudden worsening, we're always looking for some other cause that triggered that worsening that's not directly the Parkinson's. But, you know, unfortunately, as the years go on, we do consider when Parkinson's is a progressive disease, and sometimes the tremor, worse of tremor is part of that progression, or maybe a sense that the levodopa isn't helping as much as it used to. Maybe for the first couple of years, it had completely stamped out your tremor, and now your tremor is kind of starting to break through again in different situations. And so then that might mean that in that case, probably on a more sort of long-term course or more gradual course, that is probably would signify a progression of the condition and potentially a need for a higher dose of the medicines to help the tremor more again, or these other treatments like we talked about, like the deep brain stimulator or the focus ultrasound.
Yeah, thank you for that. When we think about tremors, often it's in the extremities. Some people hear describe about internal tremors, and then you yourself, and somewhat related, we talked about this uh, issue with dystonia, often in the feet, but sometimes in the face. How do
Uh,
you how do you address those? Is there like internal tremors typically handled with carbidopa levodopa, with the dystonia that you might see elsewhere outside of like the feet? Is this where botulinum toxin comes into play?
the internal tremor is an interesting thing. Some folks will say that they feel the tremor on the inside, that kind of an internal sensation of tremor. Um, that I think we look at our medicine options and we decide, you know, or maybe is it a component of anxiety that's coming out as a kind of internal sensation of tremor, and we can treat that appropriately, or with levodopa that can often help that tremor, that internal sensation as well, or other tremor medicines. But specifically for dystonias, whether they come with a tremor or not, like the woman that the video that I showed. And thank you for reminding that. I should have included botulinum toxin as another treatment option. The video that I showed with the woman whose foot is turning in at the ankle, I do treat her to this day with botulinum toxin injections to the muscles of the lower leg that pull the foot in that way, and it helps her quite a bit. And so yeah, so actually administering botulinum toxin injections, usually Botox or one of the other brand names of the treatment, is a big part of our practice in the way that we help a lot of these dystonic symptoms of Parkinson's disease, whether we're injecting it into the foot, to the muscles that curl the toes so that they relax and the curls the toes don't curl as much, or whether we inject it into the muscles around the uh, the eye or the face that cause that closing of the eyes, what we call blepharospasm. Yeah, we make a lot of use of Botox, and it can be very helpful, specifically for dystonic symptoms of Parkinson's. Just before I came in here to do this to participate in this webinar, I was doing Botox injections around the eye that have been really helpful for one of my Parkinson's patients to keep their eyes open more consistently. Before he used to have to kind of like open them manually with his hands, and he hasn't had to do that in a long time because of the Botox.
Oh, that's fabulous. I mean, I'm sure that really improves quality of life to just be able to see
Right.
consistently as you just navigate around in the world. You focus a fair bit on different type of treatment options. We just talked about botulinum toxin. One of the new ones out there is the subcutaneous pump, Vyalev, I think is how
Yes.
it's pronounced. Has it been around long enough where you've really been able to see in your clinical experience a real impact on controlling some of the tremors, the dyskinesias and things as far as that goes, or is it?
Absolutely. Yeah.
Yeah.
I think it's only been on the market for time flies for me, so I always forget. It's been about a year maybe.
Okay.
But even before that, we were part of the clinical trial and we're getting some experience using it as well. But just in that short amount of time, many of my patients have it. Usually, they are patients who um, have had the DBS, have had DBS for a number of years, and the DBS has made a big difference, but it hasn't 100% erased the dyskinesias and the fluctuations. So then we turn to the Vyalev pump. The Vyalev pump, like I said, is a device that you carry with you 24 hours a day, usually in like a little like satchel or belt or a vest. And it's attached to the skin through a little tiny plastic cannula, and that it's infusing a constant amount of liquid levodopa into your skin, and it's getting absorbed into your body 24 hours a day. And so it really is the best way that we can get somebody a constant level of levodopa in their bloodstream that gets a person out of the dyskinesias every time the oral dose peaks, and then the wearing off every time it wears off before the next dose. And it makes a big difference. It really has. I mean, it's actually just this patient that I injected with the Botox that I was telling you about. He also has one of those, and he was just telling me how much of a difference it's made for him to be able to walk consistently and talk consistently. Because before he was taking his medicines 5, 6, 7 times a day, and even then was wearing off in between and was really disabled by the difficulty walking more than anything and difficulty speaking. And now he walks and talks like you could hardly tell he has Parkinson's.
That's
So
amazing.
yeah, so we've had really good experience with the Vyalev pump already on a number of our patients. But the main issue that people need to know about is the sometimes people have skin reactions where the cannula is infusing the medicine into the skin, and so you have to be careful about that. There's a lot of training that from nurses and your doctors about how to properly manage the cannula site on the skin and how to move it every couple of days so that it's not building up it all in one spot, etc. How to be clean to avoid infections and stuff like that. So
Yeah. I'm sorry,
go
I didn't mean
ahead.
to cut you off. Yeah, go ahead, please, Dr. Coss.
Well, I was just going to say, even despite some of those skin issues, most of my patients will still it helps them so much compared to the pills, and it gets rid of the need to take the pills frequently throughout the day, which is an achievement on its own. Um, and they'll get good about you doing the cannula cleaning and upkeep and all that stuff. Yeah.
That it's just even something I hadn't considered to be able to use in conjunction with DBS as uh, you know as part of just normal care and really
I
seeing
th
such tremendous
I
effects.
think
That's
many people will think
fantastic.
of it as an alternative to DBS, which is
Yeah.
not unreasonable. I mean, it's trying to accomplish the same thing, which is to get rid of the need for frequent pills and the fluctuations, which is what DBS is trying to do. But my personal opinion is that folks with Parkinson's, if they fluctuate a lot, as the years go on, they're going to be benefited by having both, having the DBS producing the electric signaling that's helped the symptoms, and then the subcutaneous pump that gives you a continuous chemical signal to help your symptoms.
Yeah, that's interesting. Now, when we talk about DBS and other therapies, can it be used in conjunction with focused ultrasound, one or the other? Or is you if you go down that focused ultrasound pathway, are you locked into that where there's
No,
no
no, you can
no?
do the focus ultrasound, and if it works well and you don't and it accomplishes the goals and you don't need any other advanced treatments, that's great. But if it works for a while and then maybe the disease progresses as the years go on and you need one of the other treatments, you can still get a DBS, you can still do the Violet pump. Um, what you can't do is get the DBS and then try to do the focus ultrasound while the DBS is in your brain because that's well, maybe potentially you can do it, but it's not done very often. And there's a lot of considerations that might make it not a good idea.
Yeah, yeah. You don't want to heat up the wrong thing,
Right,
for
right.
sure, if it's blocking your way. Well, Dr. Costa, I really appreciate your time and your questions as they come in. I think we're coming up to the end of our time. We've went gone d decided to for the spring to make our expert briefings just a touch longer. So thank you very much for hanging in there with us and for your time today. This is a wonderful briefing on tremor, shakes, and everything in between. So if you want to see the full deck that Dr. Costa wasn't able to present, just know that we will be including that as part of an email that'll go out where you can download that as part of the process. Dr. Costa, again, thank you as part of the process. And we had lots of questions come in. If you don't have an opportunity to get a response, please know that we have our helpline, helpline at parkinson.org, or also 1-800-4PD-INFO, which is a wonderful resource. We've got tremendous colleagues there who are really helpful at handling and answering a lot of different questions as part of the process. Our next expert briefing is going to be hosted on April 8th. And so we've got one down right now and looking forward to what's going to be inside the science of Parkinson's research today. So that should be a really exciting topic. I'm looking forward to that. And then also keep in mind that this is not just the complete list of our PD Health at Home series. We have a lot of things that are available on a weekly basis, Mindful Mondays, our Fitness Fridays, and we even have programs in Spanish if that's your preferred language, or have family members who are more comfortable in that as part of the process. The key thing is we're here for you, so feel free to reach out with your questions, regardless of what they may be, and know that we're have people ready to respond as part of the process. Now, before you go, I just wanted to remind everyone that this is the Zoom world where it'll go black, but what will happen on your browser should be a briefing survey that comes up. Please fill out that survey. We use that tremendously and rely upon your feedback to ensure that what we're doing remains aligned with your needs and priorities. And we also use it to provide feedback to our speakers. We've seen some that come in very recently and they've really enjoyed what Dr. Costas had to say. So I appreciate those providing that kind of feedback. We also take constructive criticism too. We always want to figure out how to improve. So if you have any feedback, please feel free to leave it for us and we will do our best to incorporate it to ensure that we're better next time. It's always an opportunity to improve as part of the process. So until April, I wish everyone a good spring and thank you very much for your time and we'll talk again soon.